Good evening all. In this webinar, we'll be discussing about pre-discharge screening of neonates. In next 20 to 30 minutes, I will be discussing about what is newborn screening, which all diseases we have to screen, whom to screen, and when to screen. What is newborn screening? Newborn screening is a simple and inexpensive test which can tell us which babies are likely to have that particular disease. And should we screen for all possible diseases? No. We should screen only for diseases which are highly prevalent in our population, diseases which have serious consequences, and for diseases where treatment is available. Remember that any baby who tests positive on screening, that particular disease needs to be confirmed with a diagnostic test because screening is not diagnostic. The main aim of newborn screening is to detect diseases early and start early treatment and prevent complications and thereby decrease morbidity and mortality. Depending on prevalence of various diseases, we can select a different panel which suits our population. In this slide, there is incidence of various diseases prevalent in Indian population. And based on this incidence, we select our panel accordingly. This presentation has been divided into two parts. In first part, we'll discuss about diseases for which screening has to be done in both term and preterm neonates. And in second part, we'll be discussing about the diseases which have to be screened only in preterm population. For term and preterm, we need to screen them for jaundice, critical congenital heart disease, honey herring deficit, different inborn errors of metabolism depending on the prevalence in our population. We need to do a proper hip examination to detect any dislocation of hip. We need to ensure proper nutrition and ensure other systems are functioning optimally. Coming to the jaundice. Jaundice is the most common morbidity both in term and preterm, and every baby before discharge should undergo a screening transcutaneous bili check because aim is to prevent severe jaundice and thereby prevent bilirubin-induced neurological dysfunction, also called as bind. Also, there are many readmissions because of the increase in jaundice. Thereby, we can prevent those readmissions. Transcutaneous bilirubinometer, as shown in the figure, is a simple non-invasive skin test, and it can be done for babies who are more than 34 weeks and after 24 hours of life. In babies less than 34 weeks and for all babies for initial 24 hours of life, it is not reliable. Depending on the value, the pre-discharge transcutaneous bilirubin level can be plotted in this graph, which is also known as pre-discharge AAP nomogram. Along the x-axis, we have postnatal age in hours, and along the y-axis, we have total bilirubin milligram per deciliter. Remember that although this y-axis shows us serum bilirubin, but we in screening, we do only non-invasive tests, that is transcutaneous bilirubinometer. And if the level is within 2 to 3 milligrams per DL of starting phototherapy, then we can confirm it with blood test. Otherwise, we use only transcutaneous bilirubinometer for screening. This chart has been divided into 3 zones: low risk zone, intermediate zone, and the high risk zone. And depending on the level of the bilirubin, the baby can be placed in either of the 3 zones. And depending on the zone in which his transcutaneous bilirubin falls, he has to be called for follow-up accordingly. For example, in high risk zone, the follow-up has to be done within 4 to 8 hours. Therefore, baby cannot be discharged. Whereas in low risk zone, baby can be safely discharged and can be followed up after 3 to 5 days. Remember, babies with hemolytic jaundice, that is RH and ABO incompatibility disease, or sometimes rare blood group incompatibility or minor blood group incompatibility, they should stay within the hospital till we are sure about the course of bilirubin and they are either off phototherapy or we are pretty sure that they do not need phototherapy. The second common screening test which we do is pulse oximeter screening. It has to be done for all neonates, preferably at 24 hours of life or after that. If we do within 24 hours of life, the false positive rate is 0.5. Whereas if we do it after 24 hours, the false positive rate decreases considerably to 0.05. Therefore, it is preferable to do it after 24 hours of life. The aim is to detect critical congenital heart disease early and thereby decrease morbidity and mortality associated with such diseases. The screening test, when combined with physical examination, can be more sensitive. However, pulse oximeter screening in itself is highly specific to the tune of around 90 to 99%. It is not 100%. There are still some diseases which cannot be detected with pulse oximeter screening, especially diseases like coarctation of aorta, Epstein anomaly, interrupted aortic arch, and tetralogy of Fallot. For these diseases, the sensitivity of pulse oximeter screening is less than 60%. Therefore, it does not rule out all congenital heart diseases. Earlier, the cutoff was 95% and we needed to repeat 2 tests for intermediate test results. However, recently there has been a change brought out by American Academy of Pediatrics and a new protocol has been placed. In this protocol, we have to measure pulse oximetry both in preductal and postductal. For preductal, we usually use right hand, and for postductal, we can use either of the lower limbs. A patient is said to have passed the pulse oximeter screening if the pulse oximeter, that is both the preductal and postductal saturation, shows 95%, that is pulse oximetry of 95% or more in both, that is the preductal and the postductal, both saturation should be more than 95%, and there should be a difference between preductal and postductal of 3 or less. If it is there, the patient is said to have passed and we can do routine care. A neonate is said to have failed pulse oximeter screening if the saturation in either the preductal or postductal limb is below 90%, and he needs to be referred to pediatric cardiologist. However, if the tests are intermediate, that is the pulse oximetry shows saturation between 90 to 94 in either preductal or postductal limb, or there is a difference of 4 or more between preductal and postductal, that is right hand and lower limb, we need to repeat test after 1 hour. Remember, here now we have to do repeat test only once. Initially, it had to be done twice. This is because we want to cut down on the time, because 80% of the patients who fail pulse oximeter screening, they are having critical congenital heart disease. And if we repeat test 2 times, then we are wasting 1 to 2 hours and these baby can deteriorate further. Therefore, in order to save time, we do only repeat measurement only once. Also, if we do it only once, the sensitivity remains same and there is just a slight increase in false positivity rate. And even if after second measurement, the pulse oximetry shows 94% or less saturation, either preductal or postductal limb, or the difference remains 4% or more, we need to send the baby for immediate referral or screening echo to a pediatric cardiologist. However, if on repeat test the saturation shows 95% or more in both the preductal and postductal limb and the difference is 3 or less, he is said to have passed the screening test. So remember the 2 major differences in the new protocol advocated by AAP in 2020 is that oxygen saturation should be at least 95% in both upper and lower limb, and there is only 1 repeat screen instead of 2. If the saturation is low, we need to call the pediatric cardiologist for consultation and echo should be done urgently. If the saturation is very low, below 90%, and we are suspecting a duct-dependent cyanotic lesion, we can start infusion of prostaglandin E1 as early as possible and seek pediatric cardiology opinion, and accordingly we can plan further management. Other commonly missed examination is the examination of eye, which can be done with a simple test called as Red Reflex test. The test has to be done in darkened room with the help of direct ophthalmoscope at a distance of around 18 inches from the patient. It does not require any dilatation of pupils, therefore is safe and patients do cooperate well. Normally, we assess for the symmetry of the color, clarity, and the intensity of the red reflex. If there is diminished reflex, white reflex, there are dark spots, or there is asymmetry of the reflex, it is an abnormal red reflex test. Here in this diagram, on the left hand side, that is on the left eye, we see a normal red reflex, whereas in the right eye, there is a white reflex, which is often because of the retinoblastoma. And if we encounter such neonate, it has to be sent immediately to a pediatric ophthalmologist for further workup and management. Again, in this diagram, we see the first picture on the top shows a normal red reflex. Here, we see only red reflex in the right eye, whereas there is no red reflex in the left eye. Again, we see a white reflex here. Again, there is a squint present in the left eye. And again, we do not see any red reflex. Causes for abnormal red reflex can be vary, and some of the important causes are given in the slide, and these include congenital cataract, retinoblastoma, astigmatism, corneal scarring, infection, coloboma, vitreal hemorrhage, and retinal detachment. Even if we do not have direct ophthalmoscope, we can do it with the help of a phone app. We all have smartphones these days, and this app is present both in the iOS as well as in the Android phones. And this app comes by the name of White Eye Detector Cradle, and in which the camera can be used to do red reflex test, and it is very user friendly. Coming to the next set of disorders, it involves various disorders, and depending on the prevalence of these disorders, we can select a panel for our babies. It has to be done for all preterm and term neonates. It includes TSH and other diseases. For example, in India, we screen for G6PD deficiency, congenital adrenal hyperplasia, pyruvate phenylketonuria. Similarly, we can have different battery of tests for population depending on the prevalence of disease. However, thyroid is included in each and every screening. We need to do free T4 and TSH. For term babies, the ideal time to do is day 3. For preterms, we need to repeat it on day 14 or more because of the false positive high rate of TSH in the early initial period. The aim is to diagnose and treat congenital hypothyroidism early because delay beyond 1 week of age has been shown to be associated with worse outcome. And ideally, we should screen a baby for all possible inborns of metabolism using tandem mass spectroscopy. But because of the cost issues, it may not be feasible for each and every country. Commonly included diseases in majority of the countries include hypothyroidism, G6PD, and congenital adrenal hyperplasia, especially in country like ours. Another commonly missed disease is developmental dysplasia of hip. The incidence is around 1 to 2 per thousand. It is most commonly on the left side and can be bilateral in 20%. The risk factors include female child, firstborn child, family history, or if there is a breech delivery. If there are risk factors, the baby needs to be examined, and scanning in the form of ultrasound can be done at 6 weeks, or we can do an X-ray at 6 months of age. If we do not detect it timely, it can lead to precocious arthritis and chronic pain in the adolescents, and the child can have abnormal gait. And then the treatment becomes very difficult. The common sign of DDH is asymmetry, which is also known as Geleazzi sign, where the baby lies supine and both the hip and the knees are flexed at 90 degree. And here, if one knee is short, that is, if one humor is humerus, if one sorry, if one femur is short, that means that hip is dislocated posteriorly. That's why the femur is short and there is a discrepancy in the height. However, remember that if the disease is bilateral, that is seen in 20% of the neonates, the Geleazzi sign may be absent. The other common tests done for assessing stability of hip joint is Otterloni and Barlow's. Remember, the common mistake which we do is that we have to test each joint separately. And for autology test, the thumb is placed in the medial side of the thigh and the index and the middle finger are placed over the greater trochanter. In autology test, remember O for out. We have to abduct the thigh and we have to, by with the help of index and middle finger, the joint has to be pushed anteriorly so that if the joint, that is acetabulum and femur head, are not in contact, that is the joint is dislocated, and we have to see whether it can be relocated. If we hear a clunk, that means the joint has got back into the acetabulum, that is the femur head is now in contact with the acetabulum, and we hear a clunk. It is said to be have positive autology. In Barlow's, we do the opposite. We hold the joints together and we have to, instead of abduction, we have to do adduction and we have to press inwards. In this, we test the stability of the joint. Here, the joint is, that is the acetabulum and the femur head are in contact, but by displacing it backwards and pressing, we want to see whether it can be dislocated or subluxated. So we see the stability of the joint. If we hear a click, it is said to be Barlow's positive. Remember, in both the tests, we have to hold other thigh also in the same position. This is to stabilize the hip. This is not to test the both joints simultaneously. Joints have to be tested separately. Now imaging. For more than 4 weeks and less than 6 months, ultrasound is diagnostic of choice. Why more than 4 weeks is because in the initial 4 weeks, there is some physiological dislocation. And if we do ultrasound in the first 4 weeks, it will overdiagnose DDH. And less than 6 months, the secondary ossification center for femur is, for the head of the femur is, takes 4 to 6 months for the secondary ossification center to develop. And for initial 4 to 6 months, the head is cartilaginous, so it cannot be visualized on X-ray. That's why X-ray becomes modality of choice after 4 to 6 months. The AAP recommends universal ultrasound screening for DDH for all babies at 6 weeks of life. The protocol for DDH is that if autoimmune bolus continue to remain positive after 2 to 9 weeks, or if there are radiological signs suggestive of DDH, the patient has to be followed up with the imaging either in the form of ultrasound at 6 weeks or X-ray at 6 months. If there are radiological signs, then we can go for either Pavlik harness or von Rosen splint. Von Rosen splint has been shown to be slightly better than the Pavlik harness. For dislocated hip, if there is no improvement within 4 weeks, remember this is only for dislocated hip. If there is no improvement within 4 weeks of the Pavlik's harness or other splints, then the patient needs close deduction under general anesthesia and orthographic evaluation. Subsequently, spica casting can be done at 4 to 5 months of life. The other important issue for a baby is nutrition. Remember that term baby can lose up to 3% weight per day because of the loss of the extra cellular fluid. The cumulative weight loss is usually less than 10%, and majority of the term units regain birth weight by 5 to 7 days of life. In preterms, the cumulative weight loss is again 3% per day, within 3% per day, and cumulative weight loss of around 10%, and they regain birth weight by 10 to 14 days of life. In HGA, we usually do not see much weight loss because the extracellular fluid volume is less in them. So there is hardly any loss of weight. And these are the charts which can be used to assess postnatal weight loss, and accordingly, we can see whether it is normal or abnormal. Other systems we need to see for is GIT and kidney. For GIT, we need to, at the time of birth, we should palpate the palate because sometimes if it is soft, cleft in the soft palate, it can be missed by just examination. So you need to should palpate baby for a cleft with the help of finger. Should also examine the spine for any occult spinal dystrophism. Also, anal opening should be examined in each and every baby, both at birth and before discharge. And one should inquire about the passage of urine which has to be passed within 20, which majority of the babies pass urine within 24 hours and meconium within 48 hours. The genitalia in males have to be seen for the color, descent of the testis, the urethral opening, and the shaft. In females, we have to see for the ambiguous genitalia for any pigmentation. Now, the additional tests which should be done for preterm screening will be discussed in this part of presentation. The additional tests include neurosonogram for any intraventricular hemorrhage or PVL, examination of eye for retinopathy or prematurity, and additional metabolic tests for metabolic bone disease or osteopenia prematurity. We'll be discussing these one by one. The brain ultrasound needs to be done for all babies who are less than 34 weeks of gestation or any preterm who has a turbulent course. Ideally, it should be done on day 0 of life, day 1, day 3, and day 7, and before discharge. For day 0 ultrasound is to see for any perinatal insult or any congenital malformation. Day 1 and day 3 is for IVH because 90% of the intraventricular hemorrhage occur within 72 hours of life. 50% of intraventricular hemorrhage occur within first day of life. PVL usually starts by day 7 of life. So day 7 ultrasound will show us if the PVL is there. And before discharge, we can assess the severity of PVL or at term gestation age. If the baby has IVH or PVL, then they should undergo MRI at 2 to 3 months of life or whenever they are stable. Also, any abnormal clinical examination or any abnormal neurological signs, for example, seizures, such babies should undergo MRI scan, preferably at 2 to 3 months of life or earlier, depending on the examination and the possible diagnosis. If there is not feasible, we do not have access to the machine or the services are not available, we should at least do one scan between day 7 to 14 days of life, because that will tell us both regarding the presence of IVH as well as the PVL. Other common important condition is retinopathy of prematurity. It is the most common preventable cause of blindness, and it is 100% preventable. All babies who have less than 2 kgs or less than 34 weeks should undergo eye examination for retinopathy of prematurity. Also, other preterm babies who are less than 36 weeks and have turbulent course should undergo screening at 4 weeks or 3 weeks if they are of lower gestation, that is less than 28 weeks or less than 1.25 kgs. Remember, the strategy may vary from country to country. The ophthalmologist, the nutshell of this slide is that ophthalmologists should see all preterm babies less than 34 weeks and less than 2 kgs. The metabolic screening again has to be done for all babies who are less than 34 weeks because the incidence of metabolic bone diseases ranges between 10 to 40%. It has to be done from 4 weeks onward because usually the onset of metabolic bone disease is around 4 to 6 weeks. And if the test is abnormal, it can be repeated every 15 days. The common screening test which we do for a metabolic bone disease is calcium phosphate and alkaline phosphatase. The osteopenia of prematurity is usually because of the loss of the phosphate. So calcium inherently will be normal in these babies. Do not rely on calcium alone. Alkaline phosphatase is again a sensitive marker. It should usually be more than 900. Phosphorus usually less than 4.6 and alkaline phosphate more than 900 are diagnostic of metabolic bone diseases. The common clinical presentation is poor weight gain. Sometimes you can see fractures and failure to wean from the respiratory support. Can be the other modes of presentation of osteopenia prematurity or metabolic bone diseases. If a baby is having metabolic bone disease, he needs to be supplemented with calcium of around 250 milligram and 150 milligram per kg per day of phosphorus, along with good protein diet. Remember, all preterm babies who are on mother's milk need to be supplemented with iron at 2 to 3 milligrams per kg, vitamin D of 400 international units per day, along with other multivitamins. If the baby is receiving formula feeds, then again he should receive vitamin D 400 international units or iron 2 to 3 milligrams. For a term baby, vitamin D has to be started as soon as possible after birth. That is 400 international units per day till 6 months of life. Iron for term babies can be started at 4 to 6 months. Iron in preterm babies is usually started around 2 weeks of life. Other concerns before we discharge our babies that we should talk to the parents on daily basis and should allay their anxiety and talk to them and relieve them of their any concerns. Vitamin K and vaccination should be done for all babies before they are discharged. We should counsel the parents about the possible danger signs, especially in preterm babies, and should ask them when to follow up for subsequent examinations and vaccinations. Different units have different checklists, and it should be a part of the discharge summary so that we do not miss on any important examination or diseases before we discharge babies safely back to home. One of such pre-discharge checklist is given in the slide. Thank you for patient listening. Any questions, if there are any, can be asked in the chat box and we'll be happy to answer. Thank you till we meet again.